Okay, so we are going to go ahead and get started. Again, thank you for joining North Kansas City's Hospital's Dysphagia Talk. Tonight we have Stephanie Ramirez with us, and she is going to be sharing all of her knowledge and wisdom with you. So we are taking questions. You can enter your questions in through the Q&A or the chat function, and we will be answering those at the end of the presentation. We are also recording this presentation, and you can find it on YouTube at a later date. I will be sending the link around so that you can share it with others. So with that, I'll hand it over to Stephanie.
Great. Thank you, Shanna. And thank you everyone for tuning in and being here. I hope everyone had a great day. Looks like it was a beautiful day, so that's always nice. As Shanna said, my name is Stephanie Ramirez. I am a speech language pathologist here at North Kansas City Hospital. I primarily work in the outpatient setting, but I also do some acute care as well. And today I'm going to be talking all about swallowing and the swallowing disorder known as dysphagia. I know a lot of people are probably thinking, what does a speech therapist have to do with swallowing? And I always like to say that as a speech pathologist, we work everything from the neck up. So that includes obviously speaking, voice, memory, but also swallowing. And I don't know about you, but eating and swallowing is a big part of my life. So it's a topic that I think is very important for a lot of people. Okay, so my plan for tonight is to give you all an introduction into swallowing, a little swallowing 101, if you will. We're going to talk about what happens when there is a disorder of the swallow known as dysphagia. We're going to talk about evaluation and treatment options. And then as Shanna said at the end, we will take questions and I can answer any questions that you may have. So just to start off, I wanted to give us some fun facts about swallowing. So each day you actually swallow between 600 and 900 times. So we swallow a lot. Swallowing includes more than 50 nerves and muscles, and it takes less than 2 seconds. So swallowing is actually one of the most complicated functions our body does. You do swallow in your sleep. When we are talking about food, drink, or other material that you swallow, the medical term for that is a bolus. So you might hear that. And when you swallow, you do momentarily stop breathing. Your airway closes off. So just some fun facts. When we think about the swallow, it's divided into 3 phases: the oral phase, the pharyngeal phase, and the esophageal phase. And I'm going to show you on a diagram here kind of where those begin. So the oral phase is there in the yellow circle. So that is obviously involving your lips, your tongue, your teeth. You're chewing the bolus. If it is a solid, you're forming it into a little ball and you're bringing it to the back of your mouth to get ready to swallow. The oral and pharyngeal phase are the only phases that are volitional, meaning we have some control over it. The esophageal phase is not volitional. So we no longer have any control once it gets to that point. The blue circle is that pharyngeal phase. So once the bolus moves from the mouth into the throat or the pharynx, that is where that begins. And as you can see there, you have your voice box. You also have a little, I'll get my mouse here, a little pouch here. It's a little flap called the epiglottis. That is what actually flaps over to close off our airway. And usually when we're looking for aspiration, meaning food and drink is going down the airway, this is the area that we're really focused in on. And then the final phase of the swallow is the esophageal phase. So that's once the bolus enters the esophagus and is down on the way to the stomach. So I'm going to show you a couple of videos now. I think it illustrates kind of the physiology of the swallow better than I can probably explain it. So we're going to take a peek at those. And actually, let me pull it up. I think I had it pulled up earlier. Here we go.
Swallowing, or deglutition, is the process by which food passes from the mouth to the stomach. This movement is controlled by the nervous system and involves both voluntary and involuntary muscle contractions. Before food is swallowed, it is mechanically broken down in the mouth by chewing or mastication. The salivary glands secrete the enzymes lingual lipase and salivary amylase. Salivary amylase begins the chemical breakdown of starch, carbohydrates, in the mouth. The water content of saliva helps bind particles together to form a bolus that can be swallowed. Swallowing occurs in 3 stages. The first is a voluntary phase called the buccal or oral transit phase. Here the tongue moves upwards and backwards against the hard and soft palates to push the bolus into the oropharynx. Next is the pharyngeal stage, in which involuntary movements push the bolus through the pharynx and into the esophagus. Movement of the bolus stimulates receptors in the oropharynx, which send impulses to the deglutition center in the medulla oblongata and the lower pons of the brainstem. The brain signals the soft palate and uvula to close off the nasopharynx, and the epiglottis to seal off the larynx. This prevents the bolus from entering the respiratory tract. The upper esophageal sphincter relaxes to allow the bolus to move into the esophagus and contracts to reduce backflow into the pharynx. In the final esophageal stage, the bolus is pushed onward by peristalsis, a progression of involuntary wave-like contractions of the circular and longitudinal smooth muscles of the esophagus. As the bolus approaches.
All right, so that is basically a very simplified explanation, but I think it was a really nice illustration with the movements there of how the swallowing mechanism works and kind of moving from one phase to the next. When we look at it, it goes a lot faster. So I also wanted to show you a video of what we see when we are evaluating the swallow through a modified barium swallow study. And we're going to talk a little bit about this more later, but I want you to see how all of those things that she just described work together. And again, it happens in less than 2 seconds. So we're going to take a look at that. And there is no sound on this video. So if anyone is, don't panic, you're not hearing anything. All right, so pretty amazing. A lot of coordination goes into the swallow, and it goes so fast. So it is very easy to see where it could get a little bit mixed up if some of the muscles are not coordinating properly, if you have weakness. So we're going to talk a little bit about that. So dysphagia is the medical term for difficulty swallowing. And nearly 20% of adults have difficulty swallowing over the course of their life. Over 3 million cases of dysphagia are reported in the United States per year. So it is something that is very common. I feel like most people don't even realize that something can go wrong with their swallow until they're in the hospital because of it. So it's really important to know some of the signs and symptoms, some of those red flags that you might want to watch out for, and just being aware of maybe what could cause dysphagia and if you might be more susceptible to it. So again, kind of going back to the anatomy, you can see on the left, the person has the epiglottis flapped over, the larynx is closed, and the food is going down the esophagus the way that it is supposed to go down. On the right, you can see where the esophagus has not completely closed off the airway, and some of that food is actually going down the trachea into the lungs. So that would be what we would call aspiration. So aspiration is when food or drink passes the level of the vocal cords and goes into the lungs. You can also have what's called penetration, which means that it gets to the level of the vocal cords, but it doesn't go beyond them. Both of them are obviously dangerous. You don't want anything in your lungs besides air. And if you have other things in your lungs, a lot of bad things could happen. So we're going to talk a little bit about that. But first, we're going to talk about what can cause dysphagia in the first place. So I like to say that your swallow is a reflection of the rest of the muscles in your body. If your body is weak, your swallow is going to be weak. If your body is discoordinated, your swallow is going to be discoordinated. So when you have something like a stroke, when you have something like a brain injury, those types of things affect the strength and the movement of our body. Same thing with neurological conditions such as Parkinson's or dementia. You will anticipate that the swallow will be affected as well. Obviously, intubation and injury can affect the swallow, and cancer also. People that have head and neck cancer particularly are at risk for developing dysphagia. So what are the signs of dysphagia? Because although I wish I had x-ray vision, I don't. And so I can't see with the naked eye if things are going down the wrong way. So what are some of those red flags that we as speech pathologists look out for when we're assessing someone? Well, first and foremost, we look for coughing or choking. That's the first sign that something may have gone down the wrong way. And I think that we've all experienced having food or drink go the wrong way and choking and coughing until you practically turn blue. And that's normal. Everybody has that happen from time to time, but I'm talking about having it happen every time you try to eat or drink. You might notice a wet or gurgly voice because some of that food or drink might be resting on your vocal cords after the swallow, just kind of waiting to fall down. You might notice shortness of breath. You might feel like things are stuck in your throat, or you have a lump in your throat. You also might have some difficulty chewing, which can lead to obviously increased risk of choking if you're not able to chew your food completely. And so if those symptoms go on unchecked, you can have several things happen. So first, we're very concerned about upper respiratory infections. As I said earlier, we don't want anything in the lungs besides air. So if you have food or drink going into the lungs, you've now introduced bacteria into the lungs that can cause an infection. So down at the bottom there, you can see the lungs on the left have some what we would call infiltrates or things that are in there that shouldn't be in there. Causing an infection, and the lungs on the right are how they should look, nice and clear and just full of air. Another risk of dysphagia is poor nutrition and hydration. A lot of times, if it is difficult to swallow, if it takes a lot of effort, if it causes discomfort because you're coughing or choking, you're probably not going to eat as much. You're probably going to avoid those situations because it's uncomfortable for you. So then obviously nutrition, hydration suffers, and the person can become even weaker as a result. Down the line, you might have weight loss because of prolonged poor nutrition. And then eventually, people can die from complications of dysphagia because they're either not getting enough to eat or drink, or they're having recurrent respiratory infections and they're not able to clear those out. So this is definitely a serious condition. It's very common and it's very treatable. However, it's something that you definitely want to take seriously. So as a speech pathologist, I'm going to talk to you a little bit about what we look at So when we are ordered to assess someone for dysphagia, we usually start with what's called a bedside swallow study, where we see someone in the hospital at bedside or in the outpatient office. And we talk, we get a history, and we'll probably have you eat and drink some things so we can see if any of those red flags show up. If we feel like we need more information, because again, we don't have x-ray vision, and sometimes with certain conditions, such as stroke or neurological conditions, you don't always produce a reliable cough. If something goes down the wrong way, you might have what's called silent aspiration, which means that things go down the wrong way and you don't cough at all. It's silent, which is probably the most dangerous kind because you don't have any indication that it's going down the wrong way. So how do we rule that out? Well, we do a video swallow study, and you can see in the picture there, there's a speech pathologist who is giving the patient some barium to eat and drink, and then we're watching it on a screen, and that's actually the video that I showed you earlier. That was a video swallow study or a modified barium swallow study. There's also a radiologist in the room as well. Another test you might hear is fees, and that's where they go in with a little camera and they put the camera up your nose and look down your throat and watch the swallow that way. You might have an endoscopy ordered where they put a small camera down into your esophagus. They might take some biopsies, look for any tightening. They can also do CT scans, manometry, esophagram are also commonly ordered if there is a suspicion for reflux. And as you can guess, the medical team is actually composed of a lot of people. So we have the speech language pathologist who is looking at the swallow. We have an otolaryngologist or an ENT. We have a gastroenterologist that looks really from the esophagus down to see if that reflux is playing a part. We have dietitians who help counsel patients on adequate nutrition, hydration, and also neurologists if we are dealing with one of those neurological conditions such as stroke or Parkinson's or dementia. So when we are looking at a patient and we identify that they have dysphagia and they're going to need treatment for that, there are several options. It can be done in the hospital if they are an inpatient, or they can come as an outpatient. You can also be seen by home health. It's usually covered by insurance with a doctor's order. And typically we do a combination of restorative exercises and then adaptive strategies to help make the swallow as safe as possible. So when we think about restorative treatment, that's where we think about exercises that are going to help better coordinate the swallow muscles or re-stimulate the nerves that trigger that swallow. I always tell my patients the best exercise for swallowing is to swallow. So typically we'll start with whatever consistency is safer for them, and we'll just do lots and lots of swallows. I always joke that when you are in my office, you're never going to leave hungry or thirsty because we do a lot of eating and drinking. But there are also other exercises that can help, and I was going to show you just a few of them, and I thought we could kind of practice a few. Now, exercises are not going to be helpful for everybody, and they're specific exercises that we would use based on what the patient needs. But I'm just going to give you a couple examples here. So the first exercise, if the patient had like a weak tongue, we might do a tongue press. So pushing your entire tongue against the roof of your mouth and holding it for 5 seconds. So you should push hard enough so that you feel pressure in your tongue and under your chin. So everybody, let's try that. Push your tongue up and relax it down. And I always tell my patients as well, these are very small muscle groups. They're small movements. So imagine when you're going to the gym and you're lifting a small weight, it's going to take a lot of repetitions to see a difference. So typically we do these exercises, we work up to doing them 30 times each, 3 times a day. So lots and lots of swallows. The next one is a hard or effortful swallow. So you're going to swallow normally, but squeeze really hard with your tongue and throat muscles. And if you do it right, you should be able to see the effort on your neck. So I'll demonstrate. So I'm going to do a hard swallow. And you can see those muscles in my neck working. So everybody give it a try. And sometimes it's hard to trigger that swallow if you don't have any saliva in your mouth or if you're not swallowing something. So I always tell people you can grab a drink, and that can help as well. So best exercise for swallowing is to swallow. Another exercise that sometimes we'll do if these muscles in particular are a little bit weak is what's called the chin tuck against resistance. So you're going to push your forehead against the palm of your hand, and you can see those muscles in the front of my neck are engaging, and you're going to push for 30 seconds, gradually allowing your head to lower down so that by the end, you're looking at the floor. So this is almost like a sit-up for your neck muscle. And then you let go. So if everybody wants to try that one, we'll do it together. Push with your neck and start to look down and really thinking about engaging those neck muscles, keeping your hand steady and just providing moderate resistance. We don't want anybody to get hurt. But you're gonna repeat this one 3 times and rest 1 minute in between. So those are 3 examples of some different exercises we do for the swallow. Again, if you were coming for therapy, we would give you specific exercises that we would want you to do based on your specific needs. We also have some tools that we can use to help with the swallowing. So one tool is Vital Stim, and NMES stands for neuromuscular electrical stimulation. And so what that does, you can see there are little clips down here. What I do with those clips is I put a little sticker on it that has an electrode, and we put those right on the Adam's apple or the larynx so that we can see how much those muscles are moving or working. And it gives us a number so we can measure how people are getting better. And it helps them learn the exercises a little bit because actually they can see it there on the screen. They can see their muscles moving. Another way that you can use this besides that biofeedback that I just described is you can actually put electrical stimulation into the muscles. So while you're doing the exercises, the machine is stimulating your muscles, making them contract. So it's almost like you get more bang for your buck as you go through. So this treatment can be very effective. We do not use it on people that have cancer in this area. It's just not advised, at least the electrical stimulation piece. The biofeedback is fine. But it is something that you have to be trained to do. So if you are seeking out therapy and this is an option that you would like to try, make sure that you're asking to see if there's a speech pathologist who's trained to use it. And I am trained to do it here at North Kansas City Hospital. So we do that with our patients every day. The next device there is the EMST 150. So EMST stands for Expiratory Muscle Strength Training. And basically this helps with the muscles in the body that breathe out. So your diaphragm, your lungs, all of that to help you breathe out. And now why is that important for swallowing? Well, as I mentioned earlier, a cough is one of the main triggers that we look for, the red flags that we look for, but it's also the body's safety mechanism. If something goes the wrong way, it's like red alert, we got to get it out. So we're going to cough. But a lot of times if someone is weak, they can't cough hard enough to get whatever it is out. So this device will help generate that nice strong cough to help keep that person safe. It helps with breath support, and it also helps with all of that pressure and physiology changes as valves are opening and closing in the throat during the swallow. Lots of great research on this, and you can check out more if you want to on their website, emst150.com. The final device, an incentive spirometer, might look familiar if any of you have ever had surgery before. A lot of times a pulmonologist will give this to you to help get that lung function going. And now as the EMST works on those muscles of expiration, so blowing air out, the incentive spirometer is designed to work on inhalation, or blowing up the lungs and taking air in. So this can also be a very useful tool. Again, good lung strength, breath support is a really, really helpful safety mechanism if someone is known to be a chronic aspirator. On the adaptive side of things, we may talk about different ways to place food in your mouth or position your body and head to help you swallow. For example, we might instruct you to take smaller bites. We might talk about slowing down, not using a straw. Some people do better with a head turned to one side, for example, after a stroke if they have weakness. Some people do better with tucking their chin down during the swallow to help close off that airway. Again, it really depends on what your specific needs are of what we would recommend. So that's where having that good evaluation is very important. But these are just some examples of some things that we may have you try when you're here in the therapy office. Another adaptive way that we treat dysphagia is modifying the type or the consistency of the foods or liquids. So we have different levels of solids, and I will actually skip to the next slide to kind of demonstrate that. So if you see up at the top, that black area, that's your regular foods. That's everything, no restrictions at all. Moving down to the blue, we go to soft and bite-sized, so things that are going to be a little bit easier to chew, a little bit slide down the throat a little bit easier. Number 5, minced and moist, so anything like meat is going to be ground, lots and lots of lubrication with things like gravy and butter to help everything slide down. Going into the green, that's the puree. So you're thinking, things like applesauce, yogurt, pudding, and then going on to the other side, you have the drinks. So we can actually thicken liquids. And I'm going to go back to this slide. On the left, you see that the regular thin green liquid has spilled and it's gone everywhere. It's filled up the dish and it moves very fast. If I was to spill my water right now, it would go everywhere, right? So that's exactly what it does when it's in your throat. If you swallow, it'll dump down into your throat really fast and maybe go down the wrong tube because your muscles are a little bit slow. If we need to slow that liquid down to make it safer, we'll add some thickener to it. And you can see the cup on the right has the thickener, so it has spilled, but it hasn't gone everywhere. So it would be a little bit safer if those muscles needed extra time to get where they needed to go. And so again, on this, you can see all the way down at 0 in the white would be thin liquids, regular, no thickener. A 1 would be slightly thick, so this is something like maybe tomato juice. Then we have mildly thick, moderately thick, and extremely thick. So that is just adding more thickener to make the liquid move slower. I will say, as a speech pathologist, I usually do not ever recommend extremely thick. You would have to eat that with a spoon. But I have recommended the others if the person needed it, particularly if we think over a short period of time, it can help keep them safe while we're building that muscle strength back up. There's a lot of commercial thickeners out there, so I've put some of the bigger names on here. The top 3 over there, we've got the Nestle Simply or Thicken Up. There's Thicket, which is the original. A lot of times that comes in a canister. It almost looks like a coffee can. You can get that one in particular, I know, at most Walgreens or CVS pharmacies in the dietary supplement section. Simply Thick is a gel thickener. It's not a powder, so it thickens a little bit differently. Some people say it has less of an aftertaste. And that would be one that you would have to order. Some of them you have to order online. They're not available in the store. There's also pre-thickened liquids that you can purchase. So if you don't want to thicken it yourself, there's the same companies typically make a pre-thickened liquid option. And then on the bottom right, I've included this magic cup. So when we're going back to these different levels of consistency or thickness, when an object melts, when it gets in your mouth and it melts from the heat of your body, that's what we're working with. So ice cream and popsicles and things like that, when they get in your mouth, what do? They melt to a thin. So typically we don't recommend those types of things for people who are on a thickened liquid diet. However, this company here, Magic Cup, and there are some other companies out there as well, have made ice creams and things like that, that when they melt, they actually melt to a thickened liquid, a nectar liquid. So those patients can have their ice cream. Also, a lot of them are really packed with a lot of nutrition. So when I started working and I was in the nursing homes, we actually used this a lot to help patients who had some nutritional deficits. So as a speech pathologist, I feel like it is always kind of this balancing act. You know, we need to weigh what is going to keep the patient safe, but we also need to weigh quality of life. One thing, when you start messing with people's diets and you make it look different and you make it a different consistency, people are probably not going to like it at first, and they might not ever like it. So what happens? They stop eating as much or drinking as much, and then we get back to that worry about nutrition and hydration. So we have to weigh kind of the pros and cons, the risks of what their swallow impairment entails, and make a decision together. So over on the left, we have just an example of a pneumonia risk predictor. So if they have good oral health, meaning they have good teeth, they keep their mouth nice and clean. If they did not have any aspiration on their swallow test and their immune system is normal, they have a very low risk of pneumonia. Now go down to the bottom where they have poor oral health. So maybe they're missing a lot of teeth, or the teeth they have are in very poor condition. Maybe they don't clean their mouth enough, or they have sores. If they had aspiration on their swallow test and they don't have a very good immune system, that person would have a very high risk of pneumonia. So we have to kind of weigh where they land in order to make a good recommendation. And again, this is very, very specific. No two people are going to have the same swallow, and no two people will have the same recommendation. So it is very important, again, to have a good evaluation, to get that video swallow study so we can see exactly what's going on and make a very informed decision. If people do not want to do the thickened liquids, for example, because they just really don't like how it feels or how it tastes, there are other options. So I've got a little graphic there. There's something called the free water protocol. So sometimes we will allow people to eat and drink water between meals, but then during a meal, we recommend they do have the thickened liquids because you're more likely to aspirate during a meal. Water is also, you know, if your mouth is nice and clean and very free of bacteria, water is also better reabsorbed by the body than any other liquid. And obviously hydration is very important, so we want people to drink a lot of water. So just some considerations that we have to make kind of on a daily basis, and we collaborate with the physicians, with the patients, with their families, and we kind of come to this decision together and you know, move on from there with therapy and what we feel like will help them the most. So in some cases, people are not able to swallow anything safely. So maybe we do the video swallow study and everything we try is going down the wrong way. In those cases, a feeding tube may be necessary. So you might see people, short term have what we call NG tube, where it's in your nose and then goes down into your stomach. And then long term, you might have a PEG tube, which is the second graphic there, where it goes straight into your stomach through your belly. Now, I will say that I do not recommend any kind of feeding tube for somebody that has dementia. It's not proven to stop aspiration completely, because again, you could reflux and have some things come back up in your throat and have that go the wrong way. It makes people really agitated. They pull at it, they might pull it out. And it doesn't improve quality of life. So much of our life and our joy is around the table, talking, enjoying a meal together, enjoying the flavors and the smells. And if you're not able to do that, then it's really difficult. And so if this is something that is going to be perhaps a forever option, it's something that we really, really need to talk seriously about. And, especially with those with the dementia diagnosis, I think it is something that we typically do not recommend. So some common complaints that I hear from a lot of people who come into my office. Number one, I can't swallow pills. This is something that a lot of people struggle with. So if you are one of them, don't worry, you're not alone. What I always tell people is, number one, if you can't, cut the pill, try putting the pill whole in a small teaspoon of applesauce or pudding. That solid will help push it down. It gives it a little bit more weight, and it will help it go down easier than guzzling water. So you can swallow, put the pill in, swallow that whole tablespoon of applesauce, and then maybe take a drink to help wash it down. Never tilt your head back to swallow, because as you saw, our airway is in the front. So if we tilt our head back, our airway opens up. So instead of tilting your head back, I tell people, try tucking your chin down. And people are so surprised. They're like, oh my gosh, I can swallow so much easier. It's like, yes, you can, because you are protecting your airway. So just some tips and tricks for the pills. A lot of people have reflux, and that can make swallowing painful. It can make it difficult. It sometimes can cause that lump in your throat. You might feel things come back up. Like I said, with the feeding tube, sometimes that tube feeding can even come back up into your throat. So what I tell people is always stay sitting up for at least an hour after your meals. I know a lot of people say half an hour, say an hour, because you need that time to kind of digest and get things out of your stomach. And at night, instead of laying flat, use something like a wedge pillow to help keep your head elevated. It's also very important to be mindful of what you're eating. So very common trigger foods for reflux are things like fried, fatty food, spicy food, acidic food, high fat dairy, alcohol, caffeine, all of that. And I know that's all the good stuff, right? So I always tell my patients, think about it in moderation. So you don't have to completely eliminate it from your diet, but you should think about reducing those things. Another issue, a lot of people have difficulty chewing. Maybe they have dentures that don't fit well, or they don't have dentures at all. They can't afford them, or maybe they lost them. So obviously you'd want to choose things that are softer, things that are not going to require a whole lot of chewing, and really avoiding things that are dry, sticky, and crunchy. Foods like meat, bread, and raw vegetables are, usually the main culprits of difficulty with people. So avoiding those would be ideal. And actually, when I went on the internet, you can just Google soft food recipes, and there's all kinds of stuff out there. So not even for dysphagia, but for people that maybe have had oral surgery or things like that. But you could use the same thing and be good to go, get some really good ideas for how to make some good food, but food that would be a little bit easier to swallow. And now esophageal dysphagia is a little bit trickier. Again, I am not a gastroenterologist. This is their realm. Once the food enters the esophagus, we really can't do a whole lot about it. But the GI doctor can help if you have something like a stricture, a hiatal hernia, any of those things that kind of comes from chronic reflux. They can put a small balloon down to stretch the esophagus. There's different surgeries that they can do, different medications that they can use that will help kind of reduce the amount of acid in your stomach. So again, I'm not a gastroenterologist or a GI doctor, but if someone was complaining of a lot of these things, I would definitely refer them to talk to one to see what they would recommend. So some important points, if you remember our pneumonia risk table from earlier, oral care is one of the main things that we take into consideration when we think about how at risk someone is for developing aspiration pneumonia. Oral care is critical. I say oral health equals your overall health. If your mouth is in good shape, the rest of your body is probably in pretty good shape too. When you have bacteria, and I know this is kind of gross, but they say that humans have the most bacteria in our mouth out of any animal. Cats, I think, are number 2. But anyway, it's pretty gross, but we have a lot of bacteria. And so when we have that bacteria in our mouth, whatever we eat and drink gets coated in that bacteria. And then if it goes down in the airway, guess what? Now that bacteria is in your lungs. So you need to make sure that you brush your teeth at least 2 times a day. I tell people, especially if they are more prone to dysphagia, brush before and after you eat, because you want your mouth to be clean before you eat, and then you want to clean it out, make sure everything's gone after you eat. Using fluoride toothpaste, using an antibacterial mouthwash to keep everything nice and clean, and make sure that you are checking in with your dentist regularly. And then lastly, I wanted to talk about the importance of nutrition and hydration. So I know I've kind of been repeating myself saying that that is one of our biggest concerns. We want people to get good nutrition, good hydration. And a lot of times, if those are lacking, that weakness is actually what's causing the dysphagia. So it's almost a vicious cycle that we need to break. So that's where a dietitian can really come in handy, give you some good ideas for how to get more calories and protein into your day. I have a lot of patients that use dietary supplements such as Boost or Ensure to help kind of fill in the gaps if they feel like they're not getting good nutrition. Something to think about though, if you're on a thickened liquid diet, these are drinks that are not thickened. So you would have to add thickener to them. But they can be a really good way just to help, like I said, fill in the gaps if you're not getting enough to eat. And then hopefully, as you start to get more nutrition, your energy is going to increase, you're doing the exercises, your strength is going to increase, and then we can really help that swallowing issue completely resolve. So I know I've talked a lot and I've kind of thrown a lot at you, but I wanted to leave you with some resources. So North Kansas City Hospital certainly has a lot of awesome resources on their website, nkch.org. That's also where you can find information about the team that is involved in dysphagia management. There's some good resources through the National Institute on Aging and the Centers for Disease Control and Prevention. And then if it is something where you're thinking, gosh, I really feel like I want to know more, I want to get my swallow checked out or my loved one's swallow checked out to make sure things are good, or I have concerns, that number down at the bottom is the rehabilitation department. So you can always call and we'd be happy to answer your questions. As I said, therapy is covered with a doctor's order, so that can come from any doctor. So if you're talking with your doctor and you want to just get it checked out, you can have them send it over and we'll call you to get that scheduled. And then finally, I wanted to leave you with my contact information as well. So if you feel like you don't want to ask a question tonight, or you think of something later, I am definitely here as a resource for you, and I'm happy to answer any questions that you might have.
All right, thank you, Stephanie. So now we're going to open it up for questions and chat. Again, you can ask those through the Q&A or the chat feature, either or. Stephanie, do you know, you had mentioned neurological disorders, but do you know, is there a neurological disorder that dysphagia is more common with?
I would say that across all of the ones that I primarily deal with, so I see a lot of patients who have Parkinson's, I see a lot of patients who have had strokes, ALS, myasthenia gravis, all of those things. I think dysphagia is always kind of on our radar. Some people present with it early on in the disease process, and some people it takes a little bit longer. But it's something that's kind of on our radar to see, is there something that we can, get started right away to help prevent that from worsening over time.
Okay. Now, is it common for people whenever they have a surgery to have swallow tests afterwards?
So not unless the surgery is involving something with the neck and the throat. So typically, if you're having a surgery, you're intubated, you can expect there to be some irritation. My mom had foot surgery last year, and she complained of a sore throat and some irritation for quite a while, actually. But she wasn't presenting with any of those other signs and symptoms of dysphagia. So coughing, choking, she wasn't having any of that. I think if you were having some of that, the nurses who were taking care of you would probably notice and recommend that we have a swallow test done. I will say one thing, if people come in with concern of stroke, a swallow test is ordered every time, because that is something that, is frequently impacted. And so that will be something where we always have one done. Also, if somebody comes in with head and neck cancer, we always have a swallow test done, hopefully before they start their chemo or radiation, so we can get a baseline and see how their swallow is working.
Okay, let's see. Do we have any other questions? Well, like Stephanie mentioned, if you happen to think of them later, please go ahead and reach out to either her or me. And I'm going to go ahead and close out. Thank you for joining us today. I will be sending you a link to share with others. Thank you, Stephanie.
All right. Thanks, everybody. Have a good night.
Bye.